Hello, my name is Ashley MacDonald, and welcome to my online module entitled Improving APRN Communication Skills When Delivering Bad News to Patients, the SPIKES Protocol. As we all know, that when we are tasked to deliver bad news to our patients, it is not the most comfortable time that we have with them. My hopes that by the end of this program, I will equip you with a strategy that will make those serious conversations easier. Just a little bit about myself. I'm a registered nurse and currently a family nurse practitioner student at the Elms College in Chicopee. This presentation is in partial fulfillment of the requirements that I need to obtain my degree as a doctor of nursing practice. The objectives of this online module are that at the conclusion of this presentation, you will be able to identify the effectiveness of an online learning module, specify situations in which the SPIKES protocol would be beneficial to help guide the conversation, and describe aspects of the SPIKES protocol that could increase comfort and confidence when communicating bad news to patients. In order to measure these objectives, I will ask that at the conclusion of this program, you scroll down the web page and click the link that will take you to the online survey. The online survey answers that are provided will all remain confidential, and the online survey is anonymously sent back to this presenter. I keep using the term bad news, but what is bad news? For the purposes of this project, bad news is considered any information that could negatively alter the patient's perception of his or her future. So whether that's a new life-threatening diagnosis, the need to transition over to hospice or palliative care, or the death of a family member, it's important to remember in practice that bad news is subjective of the person receiving it, so subjective to the patient. So what the patient might view as bad news, the practitioner may not, and vice versa. And it's important to remember that breaking bad news to patients requires ongoing, effective, and accurate communication that some traditional communication styles may not be as effective. Just a brief background on communication and communication skills. As we all know in practice, communication is the cornerstone to providing the highest quality care we possibly can. On a daily basis, we communicate with patients and family members and physicians, physical therapists, really any member of the interdisciplinary teams. But when we first enter practice, our communication skills may not be the best that they possibly can be. Throughout my research, I have found that communication skills can be improved with continuing education, and this positively impacts our patients. It improves our relationships with them. It increases their understanding of our diagnosis and treatment plans, and has actually been shown to increase adherence to treatments. Also to note, there is very little formal education done on the art of communicating bad news when we are in our undergrad programs. So most of the time, the first time we're trying it out is when we're communicating for the first time a bad diagnosis to our patients. And as I said before, traditional communication techniques may not be effective in those stressful situations. I would now like to talk specifically about the communication of bad news. This is very important as it happens frequently in practice. It's an unavoidable aspect of care that we're going to have to eventually communicate a piece of bad news to our patients. One of the biggest barriers I found throughout my research is the level of comfort and confidence that a practitioner has when they are expected to communicate bad news to patients. I also identified that the use of a protocol or a guideline can actually make this stressful conversation easier as it guides the practitioner through and helps develop a plan of action. This brings us to the SPIKES protocol. The SPIKES protocol is the most common guideline that I found throughout my research for this project that helps guide the providers through the conversations with the patients. It was originally developed in the 1990s for use in oncology to disclose cancer diagnoses to patients, but has now been shown effective in multiple healthcare settings. It has been shown to improve communication, encourages patient-centered care, as well as increases comfort and confidence of the provider using the tool. What is the SPIKES protocol? It's a 6-step framework using an acronym that guides the APRN to break this bad news in an effective and organized, systematic manner. The acronym is S, setting, P, perception, I, invitation, K, knowledge, E, empathy, and S, summarize. I would now like to take you through the SPIKES acronym. The first S in SPIKES stands for setting. This is where all our planning comes into play. We've gotten all our test results, we've made our diagnosis, so now we have to plan for the conversation with the patient. This is also the part where we set the goals for the meeting. We want to make sure all of our information is available, treatment options, what can and cannot be done, risk and benefits. Also, rehearse the conversation and be prepared to deal with this difficult situation. We also want to think about location. We want an atmosphere that promotes privacy and quiet. So this isn't going to be in a place like a cafeteria or a waiting room filled with other patients. It'll be a quiet location such as your office. We also want to allow ourselves time to engage in these conversations. So I know this can be difficult because we have appointments that are 10 minutes long, 15 minutes long, but if possible, we might need more time than that. So an extended time block might allow us the time that we need to have this conversation with the patient. We also want to include the patient in this planning step. We want to know who they would like present. It's important to make sure the patient is the focus during this time that you've set aside for this conversations. Don't answer your cell phone, silent your pager, focus all your attention on the patient. Make sure to maintain eye contact and sit at the same level as them so they don't feel like you're above them. You could also consider telecommunication if the situation warrants it, due to long distances or if the patient is homebound or with any appointment conflicts. It may not be the best option, but if you need to relay this sensitive information to a patient in a timely manner, it may be considered and very beneficial. The P stands for perception. Throughout this step, we're going to find out what the patient knows or what they think they know about their diagnosis or their current situation. We want to evaluate their coping strategy, identify any denial or avoidance of their situation, also over-optimism. We allow the patient to describe their situation in their own words. And this would be a good time to correct any misunderstandings or misconception about their diagnosis. How we're going to do that is by asking open-ended questions. Can you describe your current medical situation to me? Tell me what you have been told so far. What have you been told about your medical condition? This will help us gather the information about what the patient knows currently. The I stands for invitation. During this step, we're going to ask the patient permission to share the information and what kind of information they would like to receive. In some cultures, the patient is not the one who initially receives the information. They prefer it done by a family member. So that's something to think about when we're engaging in these conversations. Also, ask what they want to know. Some factors that may affect information sharing I will talk about later on in the program, but just a brief overview. Culture, health literacy, and developmental level and age are all factors to think about. Some questions for this step in the protocol would include, would you prefer to have another person with you when I explain your test results? Or would you prefer if I told this information to another person first? You could also ask a question, would you like me to review your test results and tell you what I think is wrong? Some patients want all of their information told to them. Some patients want none of the information told to them. So it's important to keep this in the back of your mind throughout this step. We've set the scene, we've assessed the patient's perception of their condition, and we've asked if we could tell them the information. And that brings us to the K, which is knowledge. This is the step where you actually share the bad news. So for this step, we're going to remember to share the information very slowly. We're not going to be blunt. We're going to avoid all medical jargon and work through expectations, unrealistic, realistic expectations, explain what can and cannot be done. We want to ensure that the patient is understanding what we're telling them throughout this step. After we've told the patient the information, we're going to pause and allow time for them to process this new information and let it sink in. Start this step out with a statement. I have some serious news to tell you. I'm afraid this news is not good. Unfortunately, your test results are not as we had hoped. After you make this statement, then you can go into sharing the actual bad news. When you're done with that, again, you're going to pause and allow time for the patient to really absorb this information before we move on to our next step. E stands for empathy, and this is a very important step in this protocol. We want to display our understanding for our patient because actually that is what empathy is. It's an awareness and an understanding of other people's feelings. We do want to acknowledge our patient's emotions, which can be done verbally and non-verbally. We may feel bad, but we're going to remember that we're not going to prematurely reassure our patient that everything is going to be okay when that may not be the case. This step requires active listening. We need to acknowledge emotions and give patients and their family members time to react. This news is not easy to hear, just as much as it's not easy to give. We need to understand that the reactions of our patients and their family members is not personal, and we will encounter a plethora of emotions: denial, anger, sadness, and just confirm those, acknowledge those emotions, and understand that they are not personal towards you. How does one display empathy? You could ask them a question. Can you explain to me how you're feeling right now? This step requires active listening. Maintain eye contact with the patient. Lean into the patient. Really create an environment of intimacy and let them know you care for them. The final step in the SPIKES protocol is S, summarize. So throughout this step, we're going to do just what it's called. We're going to summarize the information that was presented, but we're also going to plan for follow-up for the next step of care. This has been shown to reduce the anxiety of patients, especially when the future is uncertain. So we're going to speak in the language that patients can understand and avoid medical jargon. We're going to also ask the patient to summarize what they understood about the conversation and clarify any misunderstandings in this step. We also want to look at the patient's goals for their future. During this step, we want to assess the patient's understanding of everything that we discussed throughout the visit and answer any questions that the patient might have at that time. We want them to know that if they get home, when they have more questions, that they can always contact the office and we could have somebody get back to them. It's important to plan for follow-up. We want to verify to the patient what's going to be happening next. What are our next steps? Do we need to go in for treatment? Do we need to schedule more appointments? And always make sure we have a sound plan for follow-up before the patient leaves. Some other considerations and barriers to engaging in this type of conversation with patients. The first we'll review is non-English speaking patients. We want to ensure that the patient is receiving the information exactly the way we want it to be understood. Having a family member interpret for the patient could alter the message. So what we will do is utilize a health system approved translator. We use the telephone lines, or we now have the iPads for computer-based translator. Health literacy is another barrier. We want to consider what the patient's education level, avoiding medical jargon, speaking clearly, and really using language that the patient understands. We also want to be culturally competent. So be sensitive to differences in cultures. For example, in some cultures, the patient is not involved in conversations and you discuss it with the family member and they discuss it with the patient later. Thank you so much for taking your time to view this online module. Just remember that below this module is a link to the online survey, which is a 10-question multiple choice survey, which should only take a couple of minutes to complete. And remember, all of your responses will come back to me anonymously.